days. And these are three key points that we will see reflected in our clinical practice. The CGRP monoclonal antibody do not have much problems with kidney insufficiency, and there was no difference in the pharmacokinetics in mild or moderate renal impairment, and they are not metabolized by the cytochrome P under 45, so we do not expect major drug-to-drug interactions. But is it worth? Well, we have been hearing, oh, it's a new molecule. We know that it's very expensive. We've got much cheaper medications to choose from. And what about long-term efficacy on the long run? How does it work? And does it really work also in chronic migraine, which is the tombstone of the headache specialist? Do we have to keep these molecules only for the desperate cases, or can we use them as a first-line treatment? And what about safety and tolerability? Well, now we can answer to many of these questions in much more proper way. And as an introduction to the talk that we are gonna see together, I will run to a few clinical cases as an appetizer, and then to hopefully to fire up some kind of discussion at the end of the talk. So the first clinical case, it's a pretty straightforward case. It's a female patient of 31 years of age suffering from migraine without aura that was referring low blood pressure and fatigue as the only information and previous medical history, and no documented thyroid disorder. Highly independent woman, low compliance for the medications, and not very happy about going to hospitals or taking care of her health, with moderate frequency, looking at her headache diary, showing 6-7 attacks each month of 1-2 days of duration each, with a total of 6 to 10 days of headache per month. No true menstrual correlation. And she was already treated before with amitriptyline that didn't work for her, and tried also topiramate that was effective, but unfortunately she couldn't tolerate because of the paresthesia and the lack of concentration and difficulty in finding words, as we know that sometimes can happen. She was a good triptan responder and also a good NSAID responder, but she noticed that she was starting using NSAIDs a little bit too much, and she was concerned about her health. So this is a pretty straightforward case that you can consider for erenumab treatment. And so she was started on 17 milligrams once per month. And at the first month, she responded pretty well, going from 7 to 3 attacks. And the subsequent visits, she further reduced to 2 attacks per month, always very quickly responsive to triptans. So let's move now to the case number 2, a little bit less typical. Again, female patients of 37 years of age, suffering from migraine without aura and occasionally from migraine with aura. Nothing relevant in previous medical history, but familiarity for migraine from mother side. Highly active, very sporty woman with a very low BMI, on the anorexia side, I would say, with a high-frequency migraine at her diary, showing 8 to 10 attacks each month, with 8 to 14 days of headache per month. The migraines were happening through the whole month and also menstrually related. Unfortunately, she already failed on amitriptyline and propranolol that were used before. Couldn't be started on topiramate because of the low BMI she was already starting with, and the eating disorder. And when we discussed about flunarizine, actually she declined, because when we were discussing about the potential side effects, she was already keen and somehow knowledgeable that could have had weight gain side effect, and she declined the flunarizine completely. She was a good triptan responder again. So the discussion went, of course, to monoclonal antibodies, and she was started on erenumab as well, 70 milligrams once per month, with a good response. Yes, improving a little bit more, going down to 5 attacks in the last month, but not much more than that. And the most attacks were still happening at the end of the month, which was the end of the month of the injection. So what I did was to anticipate the Renumab injection. Instead of having it every 30 days, we scheduled it every 26 days. And actually did make a huge difference. And she went down to 1 to 2 attacks per month and kept having these good results for several months after that clinical decision. And this is something that happened on several patients actually, and discussing also with colleagues, it was not an isolated finding that for some of these patients, we have to narrow the therapeutic window a little bit. Frequency migraine at her headache diary, 6 attacks, but unfortunately for her, the migraines were really disabling. Super severe attacks, poorly responsive to triptans, and not responsive at all to NSAIDs. So she was having big issues at her with her supervisor at her job for absenteeism. She tried before topiramate, that didn't work much for her. So we were discussing about treatment options, but looking at her file and discussing with her, we discovered that she was suffering from myasthenia gravis, and she was already on steroids and NSAID. So this led to a bigger issue, because as we all perfectly know, most of the medications that we use for migraine were falling and are falling into the potentially harmful category for people suffering from myasthenia. So beta blockers, calcium channel blockers, anticonvulsants, and tricyclics were all out of the window. So for this case, the decision was, again, this was end of 2018, was to start her on Erenumab. And using a monoclonal antibody in an autoimmune condition, we know that it's not a contraindication at all. And she responded pretty well. She was very happy because she had a reduction in the number of attacks, a couple of attacks per month, that now were much, much less severe and more responsive to symptomatic treatment, that to the point that she was able to be active at work and no longer having problems of absenteeism. Clinical case number 4. It's a chronic migraine case, and this was a pretty sort of funny case. You will see why. It was a man suffering from chronic migraine since many, many years, nearly 30 days, 28 days of headache per month, with more than 15 migraine attacks each month. He was having issues with days work lost, but social life was affected, private life was affected, high frequency at the headache diary, and elevated use of painkillers, using a lot of painkillers. Still able to manage without falling into medication overuse, because he was pretty, it was pretty clear to him that he was not having the expected result. So he's trying to manage as much as possible, even without taking medications. But the intake was still pretty high, a very high Midas score of 70, grade 4, and was already on duloxetine, 60 milligrams. It was given to him as a central pain modulator for chronic pain management as a primary effect, and of course, because he was having also mood issues. Unfortunately for him, he was already failing on most of the preventive medications that were given to him in the previous years. He actually responded to valproate that was given to him in the past, but unfortunately he could not tolerate it at an appropriate dose, so it had to be discontinued. So chronic migraine case, this should have been a clear-cut case for onabotulinum toxin, which has the indication for chronic migraine treatment. But unfortunately, this gentleman was absolutely not keen on having onabotulinum toxin, because as per him, it could have affected his manhood. Botox was something not for men, but only for women and for people with aesthetic problems, and he was not accepting this possibility at all. So he was at the point offered Erenumab, which has indication for chronic migraine, and he was started on 70 milligrams in the beginning with a fairly good response, the reduction to 8 attacks per month with 12 attacks, 12 headache days each month. And later on, he was upgraded to 140 milligrams, still ranging the same number of attacks, 8 migraine per month was the best result that we were able to achieve. But the good thing is that the number of headache days reduced a little bit more and the severity dropped consistently. So was now having 8 to 10 milder migraine attacks that make a huge difference in the quality of his life. So moving from the clinical cases to the data, we'll keep the questions for later on, as agreed and discussed with the panel. Looking at the data, these were the data from the pivotal trials for Erenumab, but I want you to focus your attention mainly on 2 trials, the Liberty trial and the registration trial for chronic migraine. The Liberty trial was an Erenumab phase 3 double-blind trial of 140 milligrams in those migraine patients with failure to 2 to 4 prior prophylactic treatments. So these were not the regular migrainous sufferers. These were what we consider sort of the refractory ones, the ones that were already failing on multiple prophylactic treatments. And the second trial that we want to focus the attention on was the chronic migraine trial. They were both successful in the double-blind registration phase, 12 weeks each of duration with an improvement against the placebo. But we want to look at the real data, real life sort of data from the open label trials that we'll review together in a couple of minutes. So keeping our attention on these 2 trials, looking a little bit more in details in the numbers, if you look at the chronic migraine trial, we can see that the change in monthly migraine days compared to placebo in the 12 weeks of the pivotal trial was pretty good, and there was a reduction in the monthly migraine days of minus 6.6. And we're having a still statistically significant response against placebo also in the Liberty trial, so in the refractory patients of minus 1.8 compared to placebo. And looking at the percentage of patients, how many patients were actually responders in these trials? So the patient with a more than 50% reduction in the monthly migraine days in the chronic migraine trial were 40%. So 40% of the patients in the chronic migraine group were having a consistent response, more than 50% reduction compared to placebo. And in these registration trials, also the refractory ones in the Liberty study, 30% of the patients were able to achieve this reduction in number of migraine days compared to placebo. So 40% of the chronics and 30% of the highly resistant ones. But let's now look at the open label extension studies that were run for Erenumab for up to 2 years. So extension from 12 weeks to year 1, year 2. The Liberty open label extension study, so these were the patients with episodic migraine failing to 2 to 4 prior preventive treatments, were enrolled and were switched to 140 milligrams once per month of Erenumab. So on the left-hand side, you can see the response in the pivotal trial, the double-blind trial, as we were saying, with 30% of patients able to achieve the reduction of more than half of the monthly migraine days. But now let's look and focus our attention in the open label extension trial at 1 year and at 2 years from the starting 140 milligram dose. They were improving in year 1 and further improving in year 2, and the proportion of patients was increasing from 30% to nearly 50% at year 1 and to nearly 60% at year 2, as able to achieve more than 50% reduction of the monthly migraine days, which was pretty striking. But not only, if we look at the sub-analysis, the percentage of patients able to reach 75% reduction or 100% reduction in the monthly migraine days. So the complete responders from the pivotal trials were 11% and 6%. At the end of the 2 years open label extension study, we're able to reach 30% of these patients. And nearly 15% of patients able to reach 75 or even 100 reduction in the number of monthly migraine days at the end of the 2 years of the open label study. And this is just a summary, just to recap with a pretty striking visual graph that, as you can see, from the beginning of the double-blind study, over the time, there was a consistent, progressive, and sustained improvement across these 2 years for both treatment groups of the patients that were on the 140, continuing 140, or placebo, moved to 140 erenumab treatment. So this was for the refractory patients, as I like to call them, the ones with a failure to many preventive medications. And what about the chronic migraine? So the chronic migraine trial, that was a 12-week study of 70, 140 against placebo, double-blind trial. The open label study was instead run as 70 milligrams against 140 milligrams. And then there was a switch of some of the patients that were on the 70, they were increased to 140. And the extension of this open label study was of 1 year, 52 weeks. So looking at the safety data, this study is with ongoing publication, so we have limited access to the information. But as we can see, the rate of adverse events reported in this comparison between the 12 weeks double blind and the open label extension at 1 year were showing the same, pretty much the same numbers. So the total number of adverse events were comparable in the first 12 weeks of treatment compared to the open label, and were not showing significant difference compared to placebo. The serious, the number of adverse events leading to discontinuation of the erenumab were again pretty comparable in the open label compared to the pivotal trial, and not different from placebo. There was no adverse event grade 4, which is hospitalization, ICU admission, or grade 5, which is death, in the erenumab trials, 70 or the 40, no difference. And the rate of grade 3 events were comparable to placebo. Most of them were viral upper respiratory tract infection or sinusitis cases and arthralgia. So again, looking a little bit more into the details on the chronic migraine data, the change from baseline monthly migraine days, as we can see in the left-hand side of the screen, in the double-blind pivotal trial, 12 weeks study, was pretty convincing. In the gray line, we see the placebo, and red and blue are the 140 and 70 milligram erenumab doses. But in the extension open label trial, you can see that all categories, once switched to erenumab, were consistently showing a progressive improvement compared to the baseline in the monthly migraine days, minus 9.3 at the end of the 1 year extension trial. And looking a little bit more in the details, the erenumab 70 milligrams compared to erenumab 140, as you can see, the higher dose was able to document an even further, an even more consistent result compared to the 70 milligrams dose in the chronic migraine treatment in terms of change from baseline monthly migraine days. So was really able to reduce the number of migraine days even compared to the 70 milligram dose, not to talk about compared to placebo.
Dr. Alessandro, only 5 minutes remaining.
Yes, just two more slides, basically. And this is just a recap of the responder rates able to achieve 50% on the left, 75% in the middle, and 100% reduction from baseline in monthly migraine days with the erenumab extension open label trial. As you can see, at the end of 1 year, nearly 60% were able to achieve 50%. 40% of the patients were able to achieve 75%, and then 12% of the patients were able to be completely migraine-free, 100% migraine-free at the 1 year extension study. And also the numbers of the use of migraine-specific medications, so the amount of acute symptomatic specific treatment was demonstrated to be reduced, consistently reduced at the end of a 1 year open label study compared to the double-blind pivotal trial. As you can see, the number of monthly migraine-specific medication was reduced to only 5 days per month in 140 milligrams subgroup and 6.5 days in the 70. Thank you for the attention, and I hope that it was sharp in time, and I don't want to take more time for the next speaker. Thank you.
Thanks, Dr. Alessandro. It's very sharp in time. We leave the question to the end of the talk. Next talk would be done by Dr. Mina. Welcome, Dr. Mina, on the board.
Welcome.
Okay. Dr. Mina is a specialist neurologist in Saudi German Hospital. He did his MD and his residency all in Egypt. And his main interest is stroke, neurocritical care, and headache management as well. His talk today will be the unmet need in headache management. Dr. Mina, go ahead.
Okay. Good evening, everyone. Today we have to speak about the unmet need in the management of migraine. We will going to share the idea of migraine and short speak about it. What is a migraine? Migraine without aura, which is international classification disorder. We have to classify that at least 5 attacks fulfilling the criteria. Attacks lasting from 4 hours to 72 hours, untreated or successfully treated. The headache has at least 2 of the following characteristics: unilateral localization, pulsating, and moderate and severe pain intensity, aggravation, avoidance, and routine physical activity while walking or climbing stairs. During the headache, at least one of the following: nausea, vomiting, both photophobia and phonophobia. Not attributed to another disorder, we have to rule out the meningitis and brain hemorrhage. We have something also be shared with the same migraine. We have to, which was going to the mimic like temporomandibular joint pain, sinus, cluster, tension, migraine, and neck pain. Usually the pain of the temporomandibular joint, usually it's coming the side of the face and usually in the front of the ears. The sinus pain usually coming at the side of the sinus. Cluster headache, we will share some about it. Tension headache, which is coming like we call it as a crown, and squeezing pain. Migraine, which our item, neck pain. Cluster headache usually involve pain around one eye. Usually there's a tearing, lacrimation, and congestion on the side of the pain. Usually lost from 7 days to 7 days. Usually it's bilateral, unilateral location. Things we were speaking about the tension headache. Usually for 7 days, bilateral, not following the criteria of the migraine, mild to moderate, usually associated with stress, no pain around it. The common triggers for migraine, we have the diet, which is like hunger, alcohol, additive, and caffeine withdrawal, usually associated with hormonal changes in menstruation, menopause, and pregnancy. Environmental, the visual, and the odors, and the parametric change, pressure change. Other like trauma, exertion, stress, and anxiety, and other change. We have about migraine, which is common in India with poor travel, work stress, education, hot weather, family stress, using some like henna application for the head, pollutions. The premonitoring symptoms, hour to days before onset of the pain, fatigue, impaired for concentration, neck stiffness. However, psychological like anxiety, depression, irritability, usually common, arousal, drowsiness. We have a photophobia and lacrimation, and frequent urine and urination, nausea, diarrhea, and food craving. The prematurity could be behavior-treated approach. We could migrate and prevent headache in this phase of the headache. When we are following, we know such we can decrease the number of attacks because 50% of our treatment depend mainly on the modification for the lifestyle, avoiding sleep deprivation, good drinking water, avoid fasting, and such things which help to decrease the number of attacks. Migraine with aura, which is the visual and sensory language distributions associated with brainstem dysfunction and associated with brain dysfunction that usually from 5 to 60 minutes before the headache. It's variable in time, and usually the common is the visual aura. There's something common with for the visual symptoms of the migraine with aura reported and the frequency. The common is flashed of bright lights and the foggy or blurred vision, zigzag, scotoma, blind spots, black dots, flaking lights, look like there's a wave or water, visual snow, white spots, bean-like and C shape, and anopia, really look closer they are related to, and microscopia and like negative film. This is a common visual coming with the aura. Aura is a paresthesia, and the second common aura symptoms usually is a congestion with visual aura. Paresthesia usually involves the hand and the pre-aura and the arm, tongue, lips, and become bilateral. We have to differentiate the aura from the TIA. It's usually bilateral in the nature and the visual and sensory symptom. Positive and negative visual phenomena occurring sequentially and simultaneously. Development symptoms over 5 minutes across the visual field, across different parts of the body and both. Sequential appearance of the aura, visual, then sensory, stereotyped and recurrent in nature. The headache, usually the headache is unilateral, 60%, and throbbing in nature, aggravated by physical activity, like head movement can be changed from side to side between the attacks. Time from 1 hour and 24 hour, range 4 hours to 72 for adults, and from 2 to 48 hours in the children. Can involve any part of the head and involves the posterior cervical and trapezius region. Usually there's a neck spasm and neck pain. Additional symptoms, we usually feel the pressure and sinus pain in 40% and cranial autonomic features in 50% of the patient. Post-dormal phase, 80% of the individual with migraine usually defaults a post-dormal phase, usually at least with lost 12 hours and can persist longer than 24 hours. Common feature for it like fatigue, somnolence, impaired for concentration, photophobia, irritability, and nausea. That's why we are usually telling that migraine is a disability process or disability disease, and decreasing the quality of the life and for the patient, not the only for the attack and for the sequence for the headache. So we are going to speak about the principle for treatment. Usually we are managing the triggers and lifestyle modification, treating the comorbid mood and anxiety, and which is playing a great role in the treat of migraine. Use of the pain relief medication, not more than 2 days a week, to prevent the development of over-induced headache. Headache diet, we usually speak about the diet which increase or decrease. Preventive medication, if severe, we have to discuss it with our patient. Choosing one of the three, we are going to choosing the right triptans. We have 3 categories: immediate acting or ultra fast. It's a sumatriptan. We use quick onset and in severe pain. Fast acting, It usually moderate onset and moderate pain, like elliptriptan and Zatran, and slow and long acting, the slow onset and long duration. We usually administer prodrome, like Frovotriptan and Noraproptan. The common combination which you commonly use is the combination between Sumatriptan and Novaproxen. We usually, it's the rules of Sumatriptan, selective vasoconstriction of the blood vessels. It also reduces the trigeminal nerve activation and vasoactive neuropeptide release, usually also inhibition of neurotransmitter release in the brainstem and upper cervical spinal column. We add the synergic effect for the naproxen, which is the reduction of the trigeminal nerve activation and inhibition of prostaglandin lead to vasoconstriction of the blood vessel. Usually, this is one of the most common used combination used in the Europe and the US, and very effective. But we usually inform that the patient should use it in the start of the headache. The greatest is the progressing of episodic migraine to chronic migraine, usually associated with opioid or palpitol containing medication, and few as 5 doses per month. To prevent complicated headache, we have to minimize using simple analgesic, less than 15 days per month, triptans, ergots, and combination between analgesics, less than 10 days per month. Preventive medication, when we're going to use, number of attacks, usually 4 attacks per month of migraine or 4 headache days per month. Headache interfere with life. Despite using all the medication and lifestyle strategy, we have to start speaking about the preventive medication. Is there any other contraindication and treatment resistance and overusing of the medication, which decreasing the effective of the disease and making the headache still there and interfering the patient life? We will use any of the preventive medication regardless to attack the frequency. For the patient who have the following rare migraine subtypes: the hemiplegic migraine, migraine with brainstem aura, and frequent prolonged uncomfortable aura symptoms, and migraines infarction. Preventive medication, usually we start with the lowest dose, increase slowly, stop escalation when the adverse effects start to happen. Consider the comorbid like a depression and epilepsy and like other disease coexisting and comorbidity like hypertension, obesity, diabetes. We recognize the monotherapy might be optimal for treating the both disorder, like using tetracycline antidepressant in treatment of both migraine and depression, and using SSRI also. 2-3 months trial is necessary to determine the efficiency. It will not come immediately in 1 month. You usually give and increasing the dose by single medication and see the effect. 6 months trial months might be necessary before maximum response is getting. Target goals, I have a goals when I using the preventive medication. I have to reduce the frequency, severity, and the duration of attacks, and a combination of all of them in one set. Discuss family planning and potential fatal effect of anti-migraine medication. We usually do this in the counseling when speaking about the migration, and usually in childbearing female patient. We usually discuss adverse drug-related events for the patient. Some might be self-limited and dose-dependent. We have goals in using the preventive therapy. We have to, as we mentioned, we reduce the number of the frequency and the severity and the duration of this disability. We improve the response to acute treatment and decrease the pain, prevent the disease and progression, because usually it started episodic and with time and with misuse of the medication, it become chronic. So we have to put the goal of the preventive therapy to prevent it from progressing and develop multiple status migrainosa. Principle of migraine preventive, that includes the patient in the choice of our choosing the medication. We have to be realistic. We are not speaking this medication is a treatment, a full recovery treatment, but it's helping medication, which is aimed to decrease the number of attacks. So it's not a complete cure from this medication. And usually emphasize the importance of minimizing use of acute treatment and getting the adverse effect of this medication, like triptans and how they affect of how the side effect of this using this medication. US headache constraint guidelines, we have group 1 medication, which is medium to high efficiency, good strength of the events. It's mild moderate side effect like propranolol, amitriptyline, topiramate, the Verilux. Group 2 medication is lower efficiency, good strength of event, and mild to moderate side effect like atenolol, metoprolol, nevidolol, gabapentin, verapamil, ketoprofen, and naproxen, and fluoxetine. Group 3, it's a good efficiency based on expert, lower strength of the event, and low to moderate side effect. It's diltiazem, tax, paroxetine, sertraline, propranolol, tamoxifen, fluoxetine. And group 4 medications, medium to high efficiency, its strengths and side effect like serotonin antagonists and MOH. The use of anti-epileptic drug, FDA approved in the preventives like topiramate and levodopa, limited evidence of migraine preventive to the gabapentin, lamotrigine, levetiracetam, and zonamide. We'll speak about those like example, which is the devarolix sodium, which is increased GABA and stabilize nerve member activation. It's around 50 to 150 daily divided BD to TID, and can be done once daily dosing, mainly drug interaction, and usually inhibit 2C19, 2D6, and CB2CD9. Usually we need to monitor the CBC, platelets, LFT, serum amylase, and drug level, causing changing the difference in bioavailability. We'll speak about topiramate, which is a common used. We usually dose and titrating dose. We usually 25 mg daily, and then titrate every week 25 grams to reach the level. Usually we need to monitor the electrolytes, usually bicarbonate and potassium. Weight, because usually it's associated with weight loss, and many of the female patients like this side effect. Hydration and the kidney stones, we have to like kidney stones, metabolic acidosis, and glaucoma. Drug and action like with digoxin and estradiol level, phenytoin, carbamazine, because we have to monitor with topiramate. Beta blockers, also if they approved for migraine prevention, the mostly used propranolol, dosage 60 to 40 mg once daily or divided BD TID. Timolol also 10 to 30 grams daily or divided dose. Limited and depend on the rest like nevidol, atenolol, and metoprolol. Beta block advantage, we through the study and widely used propranolol, FDA approved, and usually it's a very good choice when you're using it with hypertension patient or have a tremor and an anxiety, because they have a mild sedative effect. So, but we have to think about the disadvantage like side effects like fatigue, dizziness, depression, and exercise intolerance, and may also worsen the aura. Precaution in the patient with severe asthma, depression, bradycardia, and over chronic heart failure. Combination treatment, when the monotherapy combination, when we think about the combination instead of the monotherapy, we think about the synergistic effect through the action of different pathopsychologic mechanisms. Better outcome when using lower dose, because we are getting less side effect. In addition to another non-medical treatment which can be seen in Europe and many places, like avoiding the avoidance of reducible and predictive trigger factors, using of behavior treatment, including biofeedback, relaxation training, cognitive behavior therapy, and using other like acupunctures and exercise, which is very seeing effective in many countries. There's some therapeutic limitation when we have a patient with hypotension. We should avoid the beta blocker and Concertan, lisinoprolol, and others. Asthma, we didn't use a beta blockers. If I have a patient with epilepsy, tetracycline is not favorable. Obesity, we tetracycline and others not, because it's increasing the obesity. Depression, we avoid the beta blockers. And women on childbearing period, usually it's not favorable for using side effects. Glaucoma and renal stones, we not prefer to use topiramate. There's one of the common things, the migraine diet, which usually many of the patients usually discussing with you, what is the diet I should avoid, what is the diet I can eat. Usually we given the counseling, you should avoid the caffeine and the cold dairy products, big amount of meat, salty meat and eggs, also alcohols, onions, nuts, bananas, corn, tomatoes. Usually many patients have an increasing number of attacks using it. The rest of the pain-safe food migraine, like brown rice, green vegetables, green orange vegetables, yellow vegetables, and dry cooked fruits, and drinking about 2 liters of water per day. Risk of developing chronic migraine, it's common seeing, and due to severe modifiable risk factor, the high baseline attack frequency, 1 per week, overuse of acute medication, caffeine consumption, snoring due to obstructed sleep apnea, and the obesity, which is common, which is one of the area now we're seeing with many patients. And adequate treatment also of migraine. Many patients coming and they don't know they have a migraine before, and they're dealing with, as a normal headache comes, they take the normal analgesic and NSAIDs and usually get fine, and until they develop, coming to the clinic, developing the chronic migraine, chronic attacks, number of attacks is increased, and it's interfering the lifestyles. Usually it's common in the female, head injury, low socioeconomic, and depression and anxiety, and comorbid pain disorder, also risk factor for chronic migraine. Chronic migraine, we define it as a presence of headache for more than 15 days per month, or at least 8 days meet diagnostic criteria of migraine with and without aura. Using of botulinum toxin A and topiramate has been shown effective for individuals with chronic migraine. Even the acute medication are overused. We usually see this in the experience that the many patients respond before coming the era of the CGRP. Using of the botulinum toxin injection is one of the effective uses and many effective in treatment of the chronic migraine, and usually makes the patient, in addition to the other oral preventive, controlled and decreasing number of headaches. Emergency treatment. Now we are speaking about lamotrigine. It's a 5-HT1F antagonist. No activity. It's more selective, removing vasoconstrictive effect, and effective in acute treatment of migraine. CRGP functioning blocking gaptans and MAPS neuromodulation. It's coming, I think, in the market near the oral CGRP. CGRP receptor antagonist, gaptans, like effective in preventive migraine and chronic headache. It's the common two molecule is the rimagaptan and atogapan. CGRP is effective in preventive migraine and episodic migraine subjective versus topiramate. Also, the GRP has a strong efficiency in preventive migraine and migraine attacks in a chronic migraine subject versus Botox. And CGRP also effective in migraine subject who's failed other preventive. CGRP is the only effective in preventing episodic and cluster headache. This is the only glanzomab, which is only effective in preventing episodic and cluster headache. It's FDA approved for that. Migraine thing we can help. What is the trigger? Exercise, usually using exercise, eating regularly, and making time to stress, removing from stress. Migraine, diarrhea, and food. Smoking, we should be quit. Keeping good hydration and drinking good amount of water. Making sleep hygiene and sleep priority. Conclusion, migraine is, sorry. Conclusion, migraine is ranked in the sixth, the world disease. Correct diagnosis is very important. Acute treatment should be done. Preventive therapy is a best opinion for migraine patient. Drug should be individualized and selected when suits the patient. Monoclonal anti-CGRP is a long-awaited class of medication, make real game changer effect to prevent and cover unmet treatment of migraine. And thank you. This is the end of my presentation.
Thank you, Dr. Mina, for your excellent talk. We now shift the gear to question and answers. I'd like to ask the speakers to appear and let's answer some of the questions. One of the question was if botulinum toxin injection can be used for severe headache and how long it takes to act.
I think it's usually within 10 days to 2 weeks to start the efficacy, and usually it's ranged from 3 months to 4 months. And usually the patient come in the clinic for follow-up and see how's the efficacy, because usually the pain at the end of the acting of the botulinum, usually the patient's number of attacks start to be increased after being controlled. So usually we starting monitoring from 3 to 4 months. Actually 3 months is by experience we see it many patients, and usually we start applying for the next coming dose.
Okay, thanks. The other question was why to increase Erinumab might be helpful sometime in headache. Erinumab meaning that increasing the double dose, meaning giving double dose instead of one.
So this was documented in the clinical trials that in the long run, increasing the dose was able to achieve even better results compared to the standard dose. So it's not that every patient will need a 140 milligram dose, but those patients that are having a partial response on the 70 can be easily switched to 140, hoping for even further improvement. And regarding the dependency concern, I think that the change of paradigm that we have to keep in mind treating migraine with the anti-CGRP monoclonal antibodies is that we are having also from the practical experience and the clinical data a very excellent response as long as they are on the treatment window. What we still need to learn is how long they keep doing well after stopping the medication. So I don't think it will be a matter of becoming dependent, but since migraine is a chronic condition, it will come back and then they will need to start it back again. So it's not they're dependent on the molecule, it's that their condition is a sort of recurrent, a sort of chronic one, it's a recurrent one that will need further treatment again in the future. And if you can go to the following question of any role of Erinumab in trigeminal neuralgia, this is a very interesting question. Actually, there are a few anecdotal case reports of patients with trigeminal neuralgia treated with Erinumab. There is an ongoing trial that was started in October 2019 and will end in 2021. So by the end of next year, end of 2021, we should have the results of this trial, which is a 140 milligram Erinumab trial against trigeminal neuralgia. So we'll see the results from the trial hopefully next year for a more appropriate and solid response.
The other question was, is magnesium supplement a good treatment for chronic migraine headache or chronic headache?
I think using magnesium, there's some research, and usually it's Europe research mentioning that magnesium, one of the using as muscle relaxant and usually giving opportunity for relaxation and play some role in the migraine, but it's not FDA approved or nothing mentioned about using it. But we actually by experience with many patients, we can use it. It's safe, and usually the dose 370 at bedtime, it will be fine and effective.
Yes, I totally agree with Dr. Mina. Despite not being approved, there are quite consistent data and also some Cochrane reviews of the helpful and effectiveness of magnesium. So could be a good option for those patients who don't want to start a medication, a proper drug, or for very young patients, pediatric migraines, could be a good option. Totally agree.
I sometimes use it for pregnant ladies, which is safe alternative for someone with chronic headache or chronic migraine headache and pregnant, especially.
Correct.
How long should the patient take Erinumab?
This is a super tricky and interesting question. So far, what most of us have been doing was to treat patients for 6 months and then stopping the Erinumab treatment and see how long they were doing well. Actually, the information that we have from the open label, the extension studies, as you have seen tonight, are showing that the longer you keep the patients, the better actually they perform, they do. So after 6 months, if you keep them for 1 year or 2 years, they will even further improve. Of course, if you have a patient that has reached an excellent response, a couple of attacks in a month, then I think it's, for the practical side, is absolutely worth and ethical to try to stop the preventive treatment and see how long he can keep doing well. So ideally, I would probably consider 6 months as an appropriate time window, and then can be tailored a little bit on the case.
There's another question. What's the difference between cluster headache and migraine?
Usually the cluster headache have special criteria, and sometimes we misdiagnose it with the migraine. Cluster headache usually coming in one phase, unilateral, and usually coming with severe pain, throbbing pain, and usually there is lacrimation, nasal block on that side, and usually it's lost. It usually come in attacks severely in 1 month, for example, and usually it coming in attacks lasting 4 hours and then go. Sometimes with migraine. Migraine is coming throbbing, bilateral, and usually coming with other associates, other risk factor or triggers that we have been mentioned. Management of cluster is much different from the migraine. Like the recent using the recent CGRP with it. There's, I think, the special dose for it, and usually this such patient usually by experience knows that this attack is coming for this specific time of the year. For example, if it's something he has the experience of it before.
So usually cluster headache is unilateral, strictly unilateral. It has diurnal pattern, and it is associated with autonomic symptoms. So just to be simple. Can we use Erinumab as a first-line treatment?
So I would definitely say yes, we can. And I would say that depending on the case we are facing and the characteristics of the patients, we should. If I've got a patient with some comorbidity with depression, I think that amitriptyline, for example, or with insomnia, amitriptyline could still be an excellent option. But using anti-CGRP as a first-line treatment, I would say yes, because they are fast. They kick in, as we have seen, in 6 days usually. And the response rate is pretty consistent and very good, not only for the episodic migraine, but also for the patient who are failing on previous prior preventive medications. It's effective in chronic migraine, and it also works in menstrually related migraine, hormonal migraines. So I would say if it is possible, that could be a good option. Absolutely, yes.
What's a safe medication for migraine during pregnancy?
No, this is a very hard question because usually, you know, the FDA doesn't approve using any medication. Most of our medications not working during pregnancy or first, second trimester due to side effect. Using magnesium, using paracetamol, and lifestyle modification is the main. Some people using a device like Cephali, which is a common device. It's FDA approved, and other ECT device. It's coming in few hospital. I have no experience about using such machine, but I think there's some research mentioning that we can use it during pregnancy and during the acute attack. But I think we need the experience of you, Dr. Abubakr, to tell us your experience about using medication during pregnancy.
I mean, if someone is having acute headache, paracetamol, of course, in first trimester. If you read the prescriptions, it's contraindicated to use triptans, but we know now by experience that triptans are safe to be used in pregnancy. As the second trimester, then you can use NSAID. Usually dopamine antagonists are safe to use in acute headache. Steroids at times, and if the patient is having intractable or more frequent headache, then you may need to use medications such as Inderal or Triptizol. And at times I use sphenopalatine ganglion block, which contains lidocaine and safe, or occipital block. These are safe ones, a safe alternative to be used. The other question is Erinumab safe to be used in pregnancy?
We don't have data on this topic yet, and still being a pretty large molecule, is not considered safe to be given during pregnancy. There are discussions about safety during lactation, because again it's pretty large, and so the excretion rate in the breast milk should not be that high. But from the leaflet, from the approval side, we cannot say that it's approved either in pregnancy or during lactation.
Okay. Can migraine cause stroke?
So this is a very good question. Overall, I would say no, but there is a big but, especially for women. So in females, we have a subgroup of females that are at higher risk of stroke with migraine, yes, and are the women suffering from migraine with aura. So association has been documented for females with migraine with aura, and that are either taking the oral contraceptives, the pill, or that are smokers. They have a fold 7 and a fold 10 increased risk of stroke or cerebral venous thrombosis in this subgroup and subpopulation. So this is not confirmed for migraine without aura. So the most important thing is ask if the patient is having auras. If it is yes, should immediately stop smoking and not being on the pill for increased risk for stroke. Otherwise, usually are other etiological conditions that should be investigated. And sometimes people can just have an association. They are migraine sufferers and they have the stroke because maybe they've got a PFO, or maybe because they've got uncontrolled, unknown hypertension. And this can be, of course, a different matter.
Another interesting question, 23-year-old male, hypertensive, with daily attacks of headache, has tried multiple preventive medications such as antidepressant, botulinum toxin, and Emgality without any improvement. All secondary causes were excluded. What would be your next step?
I think it's hard question, because such patient, the response to medication is not the best thing. He's still young, patient. I think we saw one patient. I saw it was Dr. Suhail in the clinic. Is a young male, usually coming with severe persistent his hypertensive and uncontrolled blood pressure. Usually we can use a combination between the Botox, botulinum, and the Erinumab or the Emgality will be one of the choices. And following it closely, that's by the experience and seeing such people, patients in the clinic. But I think we need to hear experience, Dr. Abu Bakr.
Yeah, that's a difficult question. Number one, we need to see this patient, make sure that the patient really has migraine headache or other type of headaches. Number two, most people who have daily headache, you need to emphasize what do they mean by headache? Is it impacting their life or not? So it's a good idea to do migraine inventory disability score to find out how migraine is impacting their life, because the migraine at the end is a symptom. Number three, most common cause of, or one of the common cause of chronic headache, daily headache, is medication overuse headache. So we need to elicit if the patient is taking medication on a daily basis. Rule of thumb, the patient is taking medicine more than 10 days per month, those people are at risk of having medication overuse headache, and they present probably with chronic daily headache. So we need to elicit all this. At times, I mean, we find in our practice, 10% of all our headaches are having chronic headache. No matter what you do, they will have headaches. So we need to put them a goal and tell them, okay, we'll try to reduce your headache by 50%, and that's our goal. So we need to put the goal for them. Probably we need to involve other services such as psychologists, pain medicine, physiotherapists or occupational therapists to emphasize and tackle the headache in all angles. So it's a difficult question.
Maybe it could be worth also checking his hypertension and the medication for hypertension that he's taking. Sometimes we can switch them from calcium antagonist. You can switch them to candesartan, for example, and you can have an improvement, both because candesartan has some anti-migraine prophylactic effects, and also because maybe hypertension was not so well controlled as thought, and maybe this could be a secondary headache due to the hypertensive status that can have spikes of high blood pressure during the night, and they can trigger migraine, or papilledema, maybe because of intracranial hypertension, as it was called pseudotumor cerebri in the past. There could be another misdiagnosed secondary headache. And not always in very obese patients, sometimes even in not so obese patients can be worth investigating with the ophthalmologist, just to say a few.
Okay. Another question was, is there any role of steroid for acute headache?
Yes, I think we're using it as an anti-inflammatory to decrease the inflammatory effect for the migraine, and we usually use it for 24 hours to 72 hours in case of status migrainosa.
The studies actually show that the steroid prevents recurrence of the headache, so it doesn't tackle the acute headache. It's good to be used for those who have status migrainosus. They have recurrent. So steroid is good in this term of treats when you combine with it. And that's a protocol which is used by Raskin protocol. The treatment is continued for 3 to 4 days approximately. The other question is here. Is Erinumab available in primary care? The answer is yes, but you need to be a neurologist, at least in UAE, to be able to prescribe it. Okay. Dr. Mina is available?
Yeah, I'm hearing.
Yeah. How would you differentiate migraine from stroke or TIA?
As we say that sometimes the sensory aura coming with aura should be differentiated from the TIA, which is a transit ischemic attack happening, and usually it's coming with numbness and inside of the face and around the tips of the mouth and the tongue, and taking one limb or two limb. If the patient having a chronic headache, we usually chronic a history of migraine. Usually we need to differentiate, and depend on the examination we are seeing the patient, and we see any other cranial nerve affection.
Okay. Usually, what we say how to differentiate, and visual symptoms are usually sudden and it's negative phenomena in stroke, where in people with migraine are usually gradual and usually positive phenomena. And the onset of sensory symptoms or weakness are usually sudden in stroke, where in migraine people are slow and gradual. So these are the main differentials, the main differences. There's some of the questions were repeated, so I'm not going to touch it. Some people with migraine present with sinus-like headache and cervical pain. Is that usually happening for people with migraine? The question is good question. I mean, 25% of people with migraine, they do have neck pain and sinus-like headache. And most of the time they get misinterpreted by other GPs as sinus headache, but in fact it's migraine headache. So if they fulfill the criteria of migraine, I would label them as migraine headache. Can migraine cause cerebral aneurysm? The answer is no.
No, but of course, if you've got a cerebral aneurysm and you've got a sentinel bleeding, you can have a horrible headache that should not be misdiagnosed as a migraine. Should be more something like what we call a thunderclap headache. Usually are very horrible, abrupt, super acute headaches, the worst pain in the life. And that can be the first manifestation of a sentinel bleeding of a cerebral aneurysm that should be investigated with dedicated neuroimaging, MRI and MRA, or a CT angiogram. But by itself, migraine doesn't cause aneurysms.
Okay, someone who has idiopathic intracranial hypertension and her condition is stable with acetazolamide and getting worse if she stops it. Is it safe to be on acetazolamide for a long time, for many years?
So what I would probably think about is, well, as long as she tolerates and she doesn't have metabolic acidosis or any side effect from acetazolamide, she can keep taking it. If she's continuously worsening, the thing that should be probably checked is what is her body weight, her BMI, and you should find a way to have her weight lose her weight. This will be the real treatment for her, because it's believed that the adipocytes are producing testosterone hormones that trigger intracranial hypertension. The second thing that could be investigated is if she doesn't have either a chronic cerebral venous thrombosis or a leftover of a previous venous thrombosis or bilateral venous stenosis that can play a role in increasing the intracranial hypertension due to a reduced absorption of the CSF, leading to a chronic idiopathic intracranial hypertension. And this maybe could be also another reason why she's not really improving, even if maybe losing the weight.
Okay. And usually idiopathic intracranial pressure it's a hot topic. The duration of treatment is controversial. What I would do in my practice, I keep them for 1 or 2 years, and I'll try to taper it slowly. If the papilledema or the symptom come back again, then the patient will continue for it lifelong most of the time. Does migraine lead to psychological disorder? Obviously, yes. Does oral contraceptive medication cause migraine?
Usually it's not causing migraine, but it's we've mentioning in the that there's a hormonal disturbance in the menstruation, usually coming with increased number of attacks, and usually the menstrual cycle itself coming with a number of more of attacks due to hormonal disturbance. And usually if our patient usually complaining of the headache number of attacks is related to the menstruation, usually we send it to the OB-GYN to seeking for another medication, hoping to decrease the number of attacks.
Okay. Can migraine lead to psychological disorder like depression?
If I
yes, sometimes we don't know if it's the chicken or the egg. Is it depression causing migraine or migraine causing depression? And sometimes chronickers or chronic headaches, we do find at most of the time underlying depressive symptom or anxiety.
Yes,
do you agree, guys, with
that? They are probably overwired because we know there are cross connection in the pain matrix together with the area, the frontal lobes and the areas, the centers for also for depression, and probably there is a sort of genetic co-segregation. So apparently people with migraine are more predisposed to have depression and vice versa, but not always because one is causing the other. They just come together in the same genetic set.
Okay, another question. Does or can refractory errors cause migraine or contribute to migraine? Not to my knowledge, but it may aggravate the migraine symptoms or underlying migraine headache. When any trigger factors can contribute to migraine if the patient is having underlying migraine, and that would be lifestyle, insomnia, stress, depression, medication. All these can trigger migraine headache. But those patients must be having underlying migraine to begin with. Does pituitary microadenoma cause headache? Dr. Mina can answer this question.
Yes, pituitary microadenoma is associated with normal headache, not the migraine we're speaking about. And it's one of the symptoms, usually coming blurred vision, cranial nerve affection, but not migraine, as per to my knowledge.
Okay. Usually, macroadenoma, if it's pressing the vital organ in the brain, it may cause intracranial or increased intracranial like headache, and that should be a very big one associated with bitemporal hemianopia most of the time, but not migraine headache, to my knowledge. I agree with you. We're gonna end with one more question. Is earphone playing a role in causing headache? The question, possibly yes, but there are no studies done for this. So I'm not clear about whether it causes headache or not. So we conclude the talk. Thank you very much for everyone attending this talk. I see that there are 771 participants, so I'm amazed about the number of the audience here. And Friday, at least for us. So thank you everyone for attending this talk. We're looking forward to see you tomorrow, day 2, TEDx series. Just to remind you, housekeeping issues. The CME point will be sent to your email in 2 weeks' time, and it is 2 CME hours. Looking forward to seeing you tomorrow, and thank you. Goodbye.